The following podcast is part of a certified educational activity titled Confronting the Challenges of Nontuberculous Mycobacterial Lung Disease, Expert Strategies for Reducing Diagnostic Delays and Improving Adherence to Guideline-Based Treatment. Access the entire activity and complete the post-test at peerview.com/MNQ860. Downloadable slides and practice aids are also available.
Hi, welcome to Confronting the Challenges of Nontuberculous Mycobacterial Lung Disease, Expert Strategies for Reducing Diagnostic Delays and Improving Adherence to Guideline-Based Therapy. It is a pleasure to be here with my good friend and guest, Dr. Julie Filley from University of Texas Tyler, who will be giving the first part of the talk, and I'll be giving the second part of the talk, and hopefully we'll go back and forth in this peer review broadcast. Dr. Julie Filley is Professor of Medicine. She's from the Department of Pulmonary and Critical Care Medicine at University of Texas Tyler in Tyler, Texas. A good friend and a renowned expert in this area. So Julie, thank you for being with us, and I'm going to let you take it away.
Thanks a lot, Dr. Winthrop. It's always fun to present with you. We've been friends and colleagues for a long time. And welcome, everyone. We'll go through these slides fairly quickly. We don't have a lot of time together and would love to be able to answer questions if we can. So I'm going to talk about identifying NTM and just the importance of having a low index of suspicion, rather a high index of suspicion for this disease in the right patient population and making the prompt diagnosis. I want to point out that there are a lot of species now of NTM or nontuberculous mycobacteria, over 200 in fact, and identifying more every day. The good news is that the majority of these do not cause disease in the normal immunocompetent hosts. But we wanted to point out the major ones in the United States. More than 80% of what we see is MAC, followed by M. kansasii and abscessus. And we've broken these out just for your information on slow growers versus rapid growers. The majority of what we see in terms of infection, especially again in the immunocompetent patient, is lung disease. And we see a lot of MAC, but don't forget there are others as well. Why is this important? Well, we are understanding more and more about these patients and what happens to these types of patients over time. We also understand that making the diagnosis can be complicated. These are often people that look pretty healthy. They may be very physically active and may just have insidious kind of cough-like symptoms that may prompt multiple rounds of antibiotics. And this can go on for years, in fact, before someone's astute enough to say, hey, maybe I need to investigate what's going on, because this can really cause lung destruction and severe symptoms in the right patient groups. So diagnosis is really, you need to have this index of suspicion to think about it and to make the diagnosis with appropriate sputum cultures, chest imaging combined with their symptoms. We understand that a delayed diagnosis can lead to problems. And specifically, it can lead to worsening lung function, worsening symptoms, decreased quality of life. And we understand now, too, that over time, if left untreated, many of these patients' radiographs go on to progress. We also understand that this is common. A lot of people are living in the United States with NTM lung disease, and especially around bodies of water, certain coastal areas in the South and other unique places. But this is all over the place. And so having this index of suspicion is really important. The symptoms I mentioned can confuse certain providers. It can be a chronic cough that comes and goes. It can be a cough full of mucus production. Some people will cough up blood, but this does not happen in the majority of patients. We can see chest pain, especially like pleuritic type pain, but less common. Some patients complain of fatigue, which can be very severe, weight loss, chills, some night sweats, occasionally fever, but there can be a constellation of different types of symptoms that can confuse providers at times. We also have historically thought that this disease occurs in two types of people, but we're understanding there's considerable overlap in these populations. The first is the older male smoker that can be tall and thin, but can have cavitary type lesions and is associated with a worsening prognosis and higher mortality and can be rapidly progressive. That does not mean that women cannot present with this as well. The other phenotype is more of the older female, the classic Lady Windermere syndrome, which can present with scoliosis. These patients are often thin, have pectus deformities, and they can present with midlung infiltrates with associated bronchiectasis or dilated floppy bronchial tubes. And these can be slowly progressive, but some progress faster than others. I just want to point out, as my dear friend and colleague on the line, Dr. Winthrop, has coined, Dude Windermere occurs as well. And so, again, having this index of suspicion and doing the appropriate workup is really important in all types of patients. Thinking about the host and environmental and organism risk factors, we have a lot of information on this slide, but just thinking about where NTM comes from, this lives in our environment. And so we are all exposed, but different people are exposed to varying degrees. So thinking about these things, thinking about where they come from, and then also thinking about risk factors for why someone might have NTM lung disease. Oftentimes, people have underlying bronchiectasis, but they can have cystic fibrosis, and we still diagnose this in adults, alpha-1 antitrypsin, emphysema, prior infections, and then we also understand that aspiration or GERD can be associated with these things too. Thinking about how we make the diagnosis with sputum culture and understanding that oftentimes it takes patience and time for this to grow in culture, and so this is an important aspect of the disease also. We understand that rates of NTM lung disease increase with age. And I think that this is an important slide because we understand that after the age of 60, prevalence increased more than sevenfold among both men and women, from 1.7 per 100,000 among persons aged less than 60 to 15 per 100,000 for those older 60 to 69 and 30 per 100,000 over the age of 70. So, looking at this, we understand that the rates increase with age. Within the age group of greater than 60, women had a 30% higher prevalence than men, and you can see this in these graphs. And again, this was published by Dr. Winthrop and his team, and we have other data to support this as well. I think it's also important to note that NTM rates are rising in individuals with COPD, and you can see here the incidence rate in blue and the prevalence rate in red here. I think this is multifactorial, but also, again, people are understanding NTM lung disease. They're making the diagnosis more now, and so I think this index of suspicion becomes very important. But NTM certainly can be common in patients with COPD. This slide actually shows the incidence rates by gender, and you can see the numbers listed here. Making the diagnosis. The diagnosis of NTM lung disease has not changed. Our prior guidelines back in 2007 had the same diagnostic criteria as the 2020 guidelines do, and that's you have to have a constellation of three things. You need to have symptoms compatible with NTM lung disease. We went over those. I would say cough, fatigue, weight loss are some of the most common. You also need to have characteristic radiographs compatible with NTM lung disease. And this is typically cavities or nodular bronchiectasis with these tree and bud opacities and infiltrates. And then you need to have microbiologic confirmation. So you need to obtain multiple sputums over different days, at least over the course of a week. And you need to have at least 2 positive sputums or 1 positive culture from a bronchoscopy or a biopsy. Again, the laboratory becomes very important in making the diagnosis, and you do have to exhibit some patience as it does take time for these to grow. With that, I want to go ahead and toss it back to Dr. Winthrop to talk about evidence, clinical evidence with patient factors.
You bet. Thanks, Julie. I am happy to talk about treatment and the factors that we think about when we think about starting treatment or stopping treatment or managing adverse events. This is really a very shared decision-making area of medicine. There isn't often a right answer about when to treat or sometimes even how to treat, but we do have guidelines, and we are all supposed to kind of follow them, or we should be following them to start most people the right way on therapy. But we often run into problems, and we often have to think about how to adjust things. So, some of the factors up front I think about in terms of when to start someone on treatment are, whether or not they have risk factors for progression. Sometimes you have an older scan and you get a new scan, you can see they've progressed a lot in the last 6 months. Well, then that's maybe a no-brainer. They're progressing. A lot of people just kind of hang out with low burden of disease for a number of months or years before they progress or become more symptomatic. So oftentimes we're really just kind of waiting to decide whether we should start treatment. Some of the things to consider further are such, 10 or 15% of people will spontaneously clear their sputum. So a lot of times people who have low or moderate disease burden and are not very symptomatic, you may just work on a number of things, which I'll go into in the further slides, before you pull the trigger on antibiotic therapy. Now, characteristics of patients who might clear their sputum, of course, the healthier they are, the higher their BMI, in terms of having a normal BMI, they have a low bacillary burden, i.e. their sputum's AFB smear is negative. They have bronchiectatic disease, not cavitary disease. I mean, these are the people that may be more likely to clear their sputum on their own. But I think more of the risk factors on the other side, what are the risk factors this person is going to progress and not handle their infection? Certainly low BMI, anyone with a cavity needs to start therapy right away. And then, of course, how symptomatic is the patient? And that drives a lot of our decision-making around treatment start. If they're symptomatic, then there's rationale for starting treatment, and that we want to make the patient feel better. And then also consideration around immunosuppression and other potential comorbidities might drive your decision to start someone on therapy. So as I said before, this is really not like most other infectious diseases where someone shows up with a urinary tract infection, you just treat it. I mean, that's what we do. The bacteria is in the urine, you need to clear it out. Here you have a non-sterile surface. It's an airway. It has lots of different bacteria and fungi sometimes on its surface. And sometimes these bugs get out of control and cause invasive infection. So finding that time to treat sometimes is difficult with people who have low burden of disease and very few symptoms. So this is something where we really sit and talk with the patient. We talk about the likelihood for needing multiple medications for an extended length of time, strategies for handling potential adverse events. And the 2 bullet points on the bottom of the slide really, to me, are the most important. And when I first make the diagnosis in someone, I usually spend the first 3 months doing this, focusing on improving aerobic exercise, pulmonary hygiene, and airway clearance. A lot of patients can manage a low burden infection alone with those strategies. If they've already maxed out on those things, then you're closer to needing to start antimicrobial therapy. So those are the things we really spend the first few months talking about and doing before we progress to starting antibiotics. I do rely on members of our interprofessional team. I wish I had more access to these things. I think Julie has more of this at Texas. But our pharmacists, our nurses, our NPs and PAs can be very helpful, particularly around monitoring and assisting with treatment adherence or medication compliance, monitoring adverse events, checking drug-drug interactions, et cetera, and just providing counsel and really adverse event troubleshooting for patients. That's something that I find invaluable that those around me can help do. In terms of guideline-based therapy, I'm going to show you the guideline-based therapy in a second. I will show you this data first. It was just published in Clinical Infectious Diseases from Dr. Jen Koo, who is someone who used to work with me and still works with me from afar, but I hope to get her back one day. But this was a great study looking at Medicare data, 9,100 plus Medicare recipients. Now, this data was several years old. I think the end point of the data was 2016, if I remember correctly. So maybe things have gotten better since then. But up until that time, we found when we saw people in the database who were diagnosed with NTM and started treatment, 51% of them started the guideline-based therapy. And that guideline-based therapy is a macrolide, ethambutol, and a rifamycin. Again, I'll get into it in a second on the next slide. But so what surprised us was only half the patients who were starting the therapy were starting the recommended therapy. And then even more surprising, at 6 months, only 41% of those were still on the guideline-based therapy. And you can see it drop off severely at 12 months and 18 months. So what we don't know yet is why patients are discontinuing therapy so quickly. Sometimes it's just the individual drug and not the whole regimen. And we presume it's due to adverse events, but we need to look more into this. And tolerability is certainly probably an issue. I don't know, Julie, what do you think? What do you see in your practice along these lines? Are people bouncing off, on and off their Rifampin or their Ethambutol, or how do you see it?
Yeah, I mean, Kevin, I'm sure you see the same thing. I see a lot of people referred to my clinic that have been on what I would consider to be just some crazy regimens, but patients can't tolerate some things. I get that. But I'm also still shocked. We've got to point out that NTM treatment, especially MAC treatment, this is a multi-drug regimen, period. You can't treat this with one drug, and you can't look at the susceptibilities and say, oh, it's susceptible to X, Y, or Z, and then just start that drug alone. Remember, the macrolide and amikacin are the two most important drugs when you're looking at the susceptibilities, but you've got to be on more than one drug.
Yeah, and I think I'm glad you brought that up, because my speculation when I looked at that data with Jen before we published it was, a lot of, and I get these phone calls all the time, and I'm sure you do too. Like, people get the susceptibility report and they say, oh, it's resistant to ethambutol, or oh, it's resistant to rifampin, so they won't use it. And what people don't know is that doesn't matter. that actually ethambutol and rifampin still work, and what they do is they protect the macrolide somehow, magically, I guess. But even though they may not have great activity alone, in combination, they are protecting the macrolide, and that's what they're there for, is really to prevent macrolide resistance.
And I'll point out one more thing, Kevin, just if a take home is, people that are experts in this field do not use a lot of quinolones to treat it. It's a drug we use when other things don't work, if people are intolerant, as a last resort. So it's not a drug that we would ever pair with a macrolide by itself.
Yeah, it's really not like TB. And I think that's the reflexive thing here is, oh, it's a mycobacterium like TB, I'll throw Moxie at it or Levaquin at it. But very few of the MAC isolates in the country are actually susceptible to those drugs. And, very few abscesses. So I think that's a good point. I'm glad you brought it up. Well, let's move on to the guideline-based therapy, because we've been talking around it, but here it is on a slide. And as Julie pointed out, really the only susceptibilities you care about is the macrolide and the amikacin, and really just the amikacin if you're going to need to use it. You don't need to use it in most patients right off the bat. You might need to use it later. In terms of the treatment algorithm, you can see there, if they're macrolide sensitive, then you go to the left on the slide. And you go down, if they have cavities, they get 3 drugs: azithromycin, rifampin, and ethambutol, but they also get amikacin intravenously if possible. I mean, we use this in everybody with cavitary disease unless it's not possible. If they lack cavitary disease, you can either do 3 times a week or daily azithromycin, rifampin, and ethambutol. So azithromycin is the macrolide of choice. You can also use chlorothromycin, but azithromycin seems to be better tolerated than chlorothromycin, so that's why we favored it in the guidelines. The same thing is true of rifampin and rifabutin. Rifampin is favored because it's better tolerated than rifabutin. You can see on the right side of the slide, if someone's macrolide resistant, kind of all things are off. So if they lack macrolide sensitivity, then you still think about using rifampin and ethambutol, but you've got to get creative and add other drugs. Clofazimine is an option. We just talked about the quinolones as not being great options, but if you don't have other options, that might be what you turn to. You certainly would turn to IV amikacin. You can think about surgery if needed. And then there's some exotics: linezolid, tedezolid, and bedaquiline. And I do have a number of patients on these who have drug-resistant or macrolide-resistant disease. But a lot of these patients, they don't have great choices. I don't know, Julie, if you want to add anything to that.
I think it's well said. If they're macrolide resistant, sometimes you just have to phone a friend, call for help.
I sent them all to Texas. Listen, patient follow-up after MAC lung disease therapy. So we treat for 12 to 18 months generally. So our goal is to treat 12 months post-culture conversion. Most people convert their culture negative in the first 6 months of therapy. So that's where you end up in this 12 to 18 month range. After you stop, then, you can either tell them never to come back, or you can be smart and tell them to keep coming back after they stop therapy. So during therapy, actually, this slide's a mix of things here. During therapy, we typically check labs every 1 or 2 months. That's a CBC and a comprehensive chemistry. If they're on thyroid replacement, I also check their TSH because rifampin will interact with their levothyroxine. We tend to see them clinically every 2 to 3 months. We tried to get microbiologic analysis done, AFB sputum done every 1 to 2 months while they're on treatment, at least until they turn negative, and then probably less frequently after that. I shoot a chest CT on everyone 3 to 6 months after starting treatment just to make sure they're going the right way. And then we typically do one at the end of therapy to take a snapshot at the end of therapy for future use. And then after treatment, and it's not on the slide, but after treatment, I would just say there is need for ongoing disease surveillance because many of these people will relapse or be reinfected from the environment. So I tend to see these people back still every 4 months, even after they've stopped their therapy. Sometimes more frequent, sometimes less frequent, depends on what their lungs look like and how they are symptomatically. But post-treatment surveillance for recrudescent infection, I think, is important. Failure of culture conversion. So I just told you most patients will convert their sputum to negative in the first 6 months. However, about 15 to 25%, something like that, depending on which case series you choose, they will not, and they will remain positive. And these are patients we deem as being refractory. They're refractory to standard guideline-based therapy. So at 6 months, they should be negative, but they're not negative yet. So the guidelines that were recently released, in those guidelines, we recommend adding a specific treatment to those individuals to enhance the chance that they're going to convert their culture to negative. And this is ALIS, or Amikacin liposome inhalation suspension. And it's basically IV amikacin. It's 590 milligrams of amikacin, and it's encapsulated in the liposome for inhalational delivery. It has its own special nebulizer. That liposome allows the amikacin to penetrate airway biofilm and also end up intracellularly in alveolar macrophages. These are places where, both of those places are where MAC and other NTM can hide out. So this does bring the amikacin closer to those organisms. And with that, you'd expect increased killing, and that's what we've seen clinically. And this was the pivotal trial that led to ALIS being approved for refractory disease. And these are individuals who had refractory disease that came into the trial. Half were kept on GBT alone, or I should say 1/3 were kept on GBT alone, and the other, it was a 2-to-1 randomization. The other 2/3 got ALIS on top of their guideline-based therapy. And you can see by the end of month 6, and these are people who were converted at the end of month 6, which meant they had to start converting at least by month 4 because the definition of conversion was 3 negative monthly cultures in a row. But you can see we got 29% of patients to convert, so about 30% converted versus 9 who converted on the background guideline-based therapy. So it did improve the chance that these patients would convert. And again, this is now the recommended additional therapy at that time point. And of the patients who converted, what was nice to see in the ALIS arm, 63% of them on the left-hand side of the slide there, 63% continued to maintain their conversion all the way to the end of the study, whereas only 30% of the patients in the guideline-based therapy who converted stayed converted. And then on the right-hand side of the slide, you can see the bars representing those who stopped treatment at the end, who are still negative, who then, when we reassess them 3 months later off of all treatment, were still negative. And you can see of the ALIS group, the people that stayed negative to the end, they stayed negative 3 months after therapy, all of them. And of the 3 people in the GBT group, they all actually recrudesced and had positive cultures. So there was evidence here that it improved culture conversion and improved sustainability and durability of culture conversion, even at least with a 3-month window after stopping treatment. So with that, I'll mention some of the common adverse events. And Julie, I'm going to ask you to weigh in here on what to do about them. One thing we see in the trial, in the phase 3 trials, we see it in clinical practice too, is dysphonia. Some patients have increased cough and dyspnea, just airway reactivity. The kinds of things we see with a lot of inhaled antibiotics, we definitely see with this inhaled antibiotic a sense that there may be an increased risk of tinnitus. You can see 7.6% with the ALIS group as compared to 0.9% in the non-ALIS group. We did measure serial audiograms. We did not see a decrement in hearing capacity at all between the two groups, which was reassuring, but we do see this potential side effect of tinnitus. Otherwise, much of these side effects were non-serious, and they were centered around airway reactivity and hypersensitivity. And before we get there, well, actually, Julie, I'm going to let you weigh in on that in a couple slides, because let me get through the ALIS stuff here, because I wanted to point out two more things. We did do an open label extension trial too, which was really nice. And we took patients with refractory disease from that phase 3 trial, and if they didn't convert their culture and they were still positive at month 6, we basically kept the group on ALIS. We kept them on ALIS, and the people who hadn't been on ALIS before, i.e. they were in the comparison group that was just GBT alone, we swapped them over to ALIS, and we went to see what would happen. And what was cool is the people that swapped over to ALIS, so these were people who were culture positive at month 6, but they hadn't been on ALIS yet. When they swapped over to ALIS, by month 10, about a third of them were culture negative. They had converted their culture. So we saw in that group exactly what we saw in the overall study starting at time 0. And if you looked at the patients who actually started on ALIS and they were still culture positive at month 6, and they stayed on their ALIS, they stayed in the trial, we actually got a few more of them to convert. We got 13.7% of those individuals to additionally convert. So there may be some rationale for leaving someone on ALIS even past a 6-month time period if they haven't converted yet on it, because we're still probably going to get some people to convert. And then lastly, a mention about ALIS, some new data. This was just presented at American Thoracic Society conference. This was looking at individuals from Medicare and commercial insurance plans. It was looking at just overall hospitalizations in the 6 months before they started ALIS, and then the 6 months, comparing that to 6 months or other time periods after ALIS start. And as compared to the 6 months before ALIS start, you could see that patients were less likely to be hospitalized. So 28% to 43% fewer patients had respiratory-related hospitalizations during and after ALIS start. And again, the respiratory-related hospitalizations decreased quite a bit, by 40 to 44% after ALIS initiation and follow-up. So I don't know what this means, other than probably the ALIS might help diminish other bronchiectasis exacerbations. Maybe the amikacin is active against other things in their airway. It also may be that they're starting this and their MAC's getting better, and so they have fewer just overall respiratory events on their own. Adverse events associated with guideline-based therapy. Okay, so Julie, let's talk adverse events. These are some of the common ones. What are your thoughts? How do you troubleshoot some of these things with GBT? And then we'll talk about ALIS on the next slide.
I think thanks, Kevin. I think it's really important to note that patients have side effects on these medicines, and you often have to change meds. So some people do not end up on the same regimen that you start. A lot of times I hear about nausea, especially with the macrolides. Sometimes you can take the medication at night and they can sleep through the nausea. If they have a rash on clarithromycin, doesn't necessarily mean they're going to have a rash on azithromycin. So you just have to troubleshoot some of this stuff. The things listed are things you should familiarize yourself with, and definitely, be on the lookout.
Yeah, in terms of QT prolongation, I don't usually check EKGs unless they're on multiple QT prolongating agents. And after a few of them, I'll stop checking as long as they're okay. Optic neuritis, I think it's rare, but we should just remind people, anyone on Ethambutol, they should be warned of vision change or report it. We do color vision monitoring every month. And when they come in, we check their vision every 3 months. But in general, I think, most patients, if you tell them about vision changes, they're pretty, these are things that they can recognize and they can report to you immediately. Otherwise, I'm not sure what else to say. Hearing loss is a big deal with IV amikacin. It's not with inhaled amikacin. It is probably an issue with long-term azithromycin use, but I'm not sure what to do about a lot of these patients because they need to be on their azithromycin. So it's something that's hard to, it's something to talk to the patient about and make decisions about. In terms of other adverse events, particularly the ALIS, Um, what are your thoughts about helping someone tolerate ALIS over time?
Yeah, I think first thing is important to set the stage. Dysphonia and cough, like you mentioned, are common. I would say the majority of patients experience some change. So, uh, just making sure they understand this can be normal is really important. I think it's also important to, sometimes even just taking a break for a day or two can help in these situations. Some people say hot tea and other things help. I don't know that there's any necessary data for that, but that can help some patients. What about you, Kevin?
Yeah, I mean, I just think with the dysphonia and kind of increased airway reactivity, a lot of that goes away with time. So I often just dose reduce people, have them take it 3 times a week for a few weeks or months, and then gradually, ramp them up. I mean, and sometimes a bronchodilator can be used before administration. That can help. So, and some of the other things on the slide have to do with GBT here, but it is true probiotics seem to help some people. Taking the meds all together with ice cream at night. That's what I tell people to do. They seem to like that. If there's
Make the
rashes,
people happy.
yeah, I mean, everyone likes to hear that from their doctor. So rashes, I mean, I dealt with 2 rashes today. I stopped everything. I'm going to go back one by one, one drug at a time once the rash abates. So these are things that you just get used to doing. And again, on the slide too, the issue of optic neuritis, which we covered. So
I was going to just mention one other thing, and that is in the study there were some people that used ALIS that had hypersensitivity pneumonitis. So if someone calls my clinic and they're short of breath, we stop the medication. Period. So just keep that in the back of your mind. Not all not all things are benign here, but the majority of patients we can get through treatment.
yeah, I'm glad you brought that up. I actually had 2 patients like that, and so I check PFTs every 6 months in patients on ALIS. Um, and again, I talk to them just like you did in terms of what to look out for. And of course, if that happens, you withdraw the drug, and sometimes you need to use steroids. Things get better, but it is possible, just like it is with any, I think, inhaled compound. So. Okay, we're at our time limit, so that was fun. But in summary, rates of NTM lung disease are rising all around the world. Diagnosis requires time. Unfortunately, cultures take time to grow. They're hard to grow sometimes, and it's hard to get sputum from some patients, so it can be frustrating. We're looking for new ways to diagnose this entity with blood-based diagnostics or other. A decision to treat is a shared decision, as we discussed, with patient risks and benefits. There are guidelines out there that recommend a specific guideline-based therapy, as well as therapy with ALIS for patients who fail guideline-based therapy after 6 months. And an interprofessional approach, again, is optimal for managing these patients. And a team can be very helpful here of pharmacists and PAs and nurses and whatnot. And like I said, I wish I had had more of them. So I think that's it. And then troubleshooting adverse events. And we can do some question and answering right now. So I guess let's launch into it. One question, Julie, what are the options for therapy intensification in someone who's failing therapy?
Well, again, you have to kind of go back to your algorithm. Certainly, when someone's failing therapy, meaning they're still culture positive despite being on guideline based therapy, you want to make sure you've got the right diagnosis. In other words, if the patient is worsening and you're doing everything you can to make them better, you need to make sure that you're not missing some other diagnosis. Whether that be you're not adequately treating their COPD, you're not adequately doing airway clearance. You need to make sure the patient's taking the medicine. But then you go back to the algorithm and figure out if there's something you can do, either maybe add IV amikacin or change the medication to daily.
Yeah, and I would just add that in making sure you're doing everything right, sometimes I check drug levels to make sure people are absorbing their drugs, and sometimes they're not. It's unusual, but it does happen. And then, of course, getting susceptibilities done on a new isolate if it's possible they've evolved resistance. Those would be the 2 things I'd add to that. And then in terms of intensification, I mean, yeah, we kind of touched upon all the drugs on that one slide. Clofazimine or IV amikacin or inhaled ALIS. I mean, and then some of the other drugs that we don't necessarily like using, but those are things we throw at people to intensify. So I think with that, we'll sign off, and thank you guys for joining.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MNQ860. This activity is supported through an educational grant from INSMED.